Okay, we're moving on to our last paper, which is Robotic against Conventional Laparoscopic Gastric Banding, a comparison of 407 cases by Dr. Paula Edelson from Department of Surgery, University of Pennsylvania School of Medicine.
Good afternoon. My name is Caitlin Edelson, and I'm a second-year medical student. I'm here today to present on behalf of my co-authors and myself a case series of robotic versus conventional gastric banding. Nothing to disclose. Bit of background. The U.S. experience with the lat band began back in 2001, and it is now a widely accepted and widely used intervention for morbid obesity. The Bariatric Surgery Center at Penn has been using this technique since 2005. Initially, all of the cases were performed laparoscopically, and in December of 2006, we adopted the robotic technique. However, the indications for performing one approach over another remain unclear. Having performed several hundred of these procedures in the past 5 years, we've become very interested in quantifying objective differences between the two approaches when it comes to operating times and postoperative outcomes. The question that we ask is, are there patients in whom one approach is indicated over another? Are there some patients in whom the robot will be beneficial? All of the cases included in our series were performed between December 2006 and June of 2009. We have a total of 407 cases, 287 of which were robotic, and 120 of which were performed conventional laparoscopically. All of the cases were performed by one of two primary surgeons at an ASMBS-accredited Center of Excellence. We retrospectively examined preoperative patient characteristics, operative outcomes, and postoperative outcomes. The preoperative patient characteristics revealed no differences between the robotic versus the conventional groups. This table lists all of the operative and postoperative complications with an N of greater than 0 reported in this series. They included conversion to open, in which we had 1 in the conventional arm, the conventional laparoscopic arm, band reoperation, band removal, port reoperation or port removal, band slippage, ER visits resulting in non-admission, and ER visits resulting in hospital admission. As you can see here, through the robotic versus the conventional, none of these outcomes were different significantly. We had the same operative and postoperative complication rates between the two groups. Sorry. This figure represents a summary of all of the laparoscopic procedures grouped by BMI. On the x-axis, we have the stratified BMIs. On the y-axis, the operating times. The center of each box represents the median time, and above and below, the third and second quartiles. The line through each box represents the total range of data. This graph shows a slight increase in operating time as we reach a BMI of greater than 50. And the mean time for this group of a BMI of greater than 50 was 101 minutes. Similar to the last one, this next slide shows a summary of the robotic procedures, again grouped by BMI. Again, on the x-axis, we have the BMI stratified, y-axis operating times. And in contrast to the previous slide, we notice a constant operating time over the course of the BMIs with no increase as we reach a BMI of greater than 50. And in fact, when compared to the conventional laparoscopic arm, we found a mean operating time of 91 minutes, which is statistically lower. So when taken as an aggregate, we found no differences between the robotic and the laparoscopic approach. No differences in preoperative patient characteristics, operative outcomes, or postoperative outcomes. This finding is significant and actually differs from the published literature on the topic, which has reported to date that the robotic technique is significantly longer than the conventional. In this large case series, we did not find this. Furthermore, upon stratifying the BMIs, we found that for super obese patients with a BMI of greater than 50, the robotic technique was significantly shorter than the conventional laparoscopic. Our N for this was 89, and to a significance of a p-value of 0.04. This chart basically summarizes all of the cases. Again, stratified BMI on the x-axis, operating time on the y. The shaded columns represent the conventional laparoscopic approach, and the white represents the represents the robotic. I'd like to draw your attention to the far right-hand side of the screen where we see the super obese population, and we can see the conventional is significantly longer in operating time than the robotic. And this difference turned out to be about 11 minutes shorter. In conclusion, in our case series, which is the largest case series published to date to our knowledge, the robotic approach was as safe and as fast as the conventional laparoscopic approach. Furthermore, for patients with a BMI of greater than 50, we found the robotic approach to be significantly faster. We attribute this largely to the mechanical advantage that the robot offers over conventional laparoscopic approaches when it comes to operating on patients with a body habitus of a BMI of greater than 50, so super obese. Furthermore, we hypothesized that because of this decreased operating time and decreased immobilization time and use of anesthesia, we hypothesized that this actually might provide a significant benefit in the super obese population who is already at an increased risk of DVTs and PEs. However, in our study, the power was not great enough to determine this, but it's something that we would like to look into in the future. So on behalf of the co-authors and myself, I would like to thank you for the privilege of presenting to you this afternoon, and thank you for your attention.